like to talk about photodynamic therapy and also about the photodynamic action. And we are looking nowadays more in direction of neurosurgery. We started with PDT and PDD through all the body. So, but now we are in neurosurgery, and yes, let's have a look what happens there. And as you mentioned already, Anna, the lab book is very, very interesting because photodynamic therapy starts in the very, very beginning of the last century. So it was 1903, somewhere in Munich. And in Munich, there was a student that was called Oskar Raab. And he got the topic to find a drug against malaria. And then he put some drugs on this malaria cells in this pharmacological lab, and nothing happened with this malaria cells. Then his supervisor told him, okay, take another drug. He did the same. And then sometimes it happens, something. The malaria cells died. Oh, that's good. We should take this kind of drug. Reproduce. Okay, he put the same drug. Nothing happened. Oops. So do another concentration. Nothing happened. Just in one or two of these petri dishes, something happened. So there were dying malaria cells. Oskar, what are you really doing? Show me your lab book. Exactly. Yes, this is my lab book. Oh, everything is fine. So please write everything very, very careful into your lab book. What happened during this day? Air pressure, humidity, and. Finally, they came up on the days when there was sunny light outside, the cell died, and when it was rainy, nothing happened. So you have to protocol the weather forecast of these days when he made his experiments. And this was the beginning of this photodynamic activities in the newer area, so 100 years ago. And it took a while that first they have seen that this drug which was given to these malaria cells is fluorescing. So they thought that the fluorescing light is making the death. And it took a long time to investigate that it is not the fluorescing dye. This is a fluorescent light, but it is this reaction in the other reaction with direction to radical oxygen, to produce radical oxygen species or singlet oxygen. And then Hermann von Tappheimer, this was his supervisor, and his friend Albert Jesonik, they asked a poor woman with this cancer whether they are allowed to paint this cancer with eosine. This was a drug available which Oskar discovered for these malaria cells. And they put some sunlight on it, and you can see here, this was in September, and this was in November. The photodynamic therapy works a little bit. Is what not complete, but there is something happening, and that is fine. And that was the very, very beginning. Nowadays, it plays another way around. So we are much, much further. I would speak today about the principles of PDT, about optical biopsies in glioblastomas, where we use also this PDT action. We use fluorescence, we make some photodynamic therapy, and I also would like to show you some technical improvements there. So we already discussed a little bit about photodynamic therapy. Normally, photodynamic therapy uses three components. One is a photosensitizer. Then we need some light, which is somehow related to the absorption bands of the photosensitizer, that the photosensitizer can be activated or excited. And then we need some oxygen nearby the photosynthesizer that the energy can transfer to the oxygen to produce something like singlet oxygen or radical oxygen species. Interesting that is if a photosynthesizer is applied, it needs what we called drug light interval. It needs a certain time to tumor selective accumulation in the cells or in the target cells. Then we can apply the light, and then this reaction here using this superoxide on oxygen and singlet oxygen production can be produced. Interestingly, a lot of these photosynthesizers also fluoresce. So this is a competitive reaction. We need, on the physics point of view, the light dosimetry concepts. And also we need anesthesia to make a very good oxygen supply within the tissue. These are the basic principles of PDT. One can use different sorts of photosynthesizers in these fields. Most of them are looking like in chemotherapy, where is the target? Roughly 25 years ago, Jim Kennedy discovered that in mammalian cells, we have this 5-ALA, a very, very tiny molecule. And 5-ALA is the first stage to produce in a metabolic way in the heme metabolic pathway to produce protoporphyrin 9. And this is a fluorescing dye. So the concept would be to apply some 5-ALA in non-fluorescing dye, and then to produce this protoporphyrin 9 within the cell. In this case, the cell itself cries, I am full of PP9 and here am I. So there is not this chasing. 5-ALA is an endogenous substance. It can be applied topically. Intracellular, we have this conversion to protoporphyrin. We have a very high tissue and tumor selectivity and very fast pharmacokinetic. And at the very, very end, also PP9 shows photobleaching. So how does it happen? Here a short introduction to the heme biosynthesis pathway. This is a cell and this is a mitochondria. In the mitochondria, we have these two drugs, glycine and succinyl coenzyme A, and they are condensed to this 5-ALA in the mitochondria. Then this is delivered to the cytosol, where 5-ALA is then by some enzymatic steps to porphobilinogen up to coproporphybilinogen, and then this molecule enters the mitochondria again, and then it forms up protoporphyrin. Normally, protoporphyrin, there is this ferrochelatase which put some iron into this protoporphyrin. Then we got some heme, and this normally had the feedback regulation about this process that it's running. When we apply some ALA from outside, and this is a ABCG2, I think ABCG2 protein transport here, and this is very nice transport taking up this 5-ALA, then we bypass this reaction and also this feedback. This reaction takes place, and because the tumor cells are highly active in this metabolic rate, then we have a protoporphyrin 9 accumulation here. Interestingly, in a lot of tumor cells, also the ferrochelatase activity is reduced. So this bottleneck we use also. So we have a high tissue penetration for this nicely little molecule with a good cellular uptake. We have high activity of these plasma enzymes, especially in the tumor cells. The activity of the ferrochelatase is reduced. The distribution within the cell is also a little bit reduced, and also is reduced the efflux of PP9 out of the cells. So we have a nicely accumulation there. Roughly 5 ALA, we need 8 of them to build up this tetrapyral ring. And within this tetrapyral ring, we have this double bond, one bond alternating rings. It's pi electron shell, which can be excited with light. The absorption spectrum is like this. We have a solid band at 400 nanometers, but there are also some Q bands here in the 500 and 600 nanometer wavelength range. And once you excite this molecule, this PP9, then you have a nice fluorescence in the spectral wavelength range from 600 to 700 nanometers. When we try to perform fluorescence for diagnostics, we use the solid band. So in this spectral region, with a low optical penetration depth, so we just get surface fluorescence. If we want to make photodynamic action, we can use this as well, but the action is not that deep. Therefore, we take the band at this low band, this low Q band at 635 to have a deeper reach into the tissue. This is how we can see here. This is for the 400 nanometer. We just have 100 microns, something like that. And here we have a couple of thousands of microns, optical penetration. So the fluorescence is like that. Here are 2 cuvettes, one with natrium fluorescein, the other one is with PP9 filled. Fluorescence needs darkness. And then we cover it a little bit, and then we shine blue light on it, and we can clearly identify that natrium fluorescein fluoresces green. The transmitted light here is enough to excite the PP9. We have a red fluorescence, and also we can see here that there is enough optical penetration through the cuvettes that we also can see the blue light here. And we can have a nicely contrast between the blue and the red light when we shine on tissue. This is how it looks like in frozen slides in urology. This is a papillary tumor here where PP9 is applied, or 5-ALA is applied. This is the HE stained tumor slide here, which corresponds very, very nicely to the fluorescence microscope slide here, where we have this red fluorescence, and underneath we have the collagen of the normal tissue underneath. And you can clearly see that it's highly, highly selective. The PDT effect is like this. We have this photosensitizers normally in the singlet state. Then it goes into, by intersystem processing, the spin change it, and this triplet state can correspond with the triplet state of the oxygen. So it is excited to the singlet state. So we have we receive some singlet oxygen, and the singlet oxygen itself reacts with some molecules within the cells to promote the cell death. Protoporphyrin 9 shows some photobleaching. This is shown here. That this is the excitation here, and this is the fluorescence. And when we use different kinds of energy or irradiations for this solution, we can clearly identify that there is a photobleaching effect here. And when we write it, make a graph against this irradiation, we can see this mono exponential decline along more or less the irradiation time or the energy applied. What we need else to apply all this also in the in tumor cells or in the hospital, we need the optical parameters to calculate for the specific wavelengths the optical penetration depth. So we can measure it by diffuse reflectance, or also with the lateral distribution of emitted light of this spot here. With this, we can get the optical parameters, and in this investigation, we did it for brain tissue, and we can see here with low optical penetration for 400 nanometers and a high optical penetration for the 635 nanometers. So then let's go further on. The aim is, in this case, the malignant glioma. It is a very, very hard to treat tumor. It is an anaplastic astrocytoma, WHO grade 3 or 4, and it is derived from glia cells, normally astrocytes and oligodendrocytes. And a lot of peoples can get it, and there is 2 to 3% of cancer deaths per year. Unfortunately, this tumor has a very, very bad prognosis. The median survival is roughly 2 years for the grade 3 stage and just 15 months for grade 4. Normally, this tumor grows very, very infiltrative into the functional brain area here. And nice resection with safety margins is in principle not possible. There are always some guerrilla cells in the neighborhood. The standard protocol for the neurosurgeons is surgery, radiotherapy, and chemotherapy. And this is a standard therapy. And we were asked whether we can use this 5-ALA-induced protoporphyrin on one hand side to perform something like fluorescence-guided resection, which we have already done in urology. So to increase the resection, especially the resection volume, because of better differentiation to the normal tissue. Or if this is not still curative, whether we can use it for 5-ALA-based photodynamic therapy. So let's go on. But from the first point, we have to go how to diagnose the tumor in the brain. So this is an artificial brain, and here is a tumor. And the problem for the taking stereotactic biopsies is like this: that you go with a specific stereotactic biopsy needle through the brain, and you can hit some vessels to induce some bleeding, and you can take either some tissue here and so on, very, very deep. Sometimes the tumor is. So, but you have to take, normally you take every half centimeter or every short while a biopsy. So we were asked whether we can improve this thing. And if we think about that, the necrotic tumor part is not fluorescing, but the vital tumor part is fluorescing after application of this 5-ALA and after this metabolization to PP9, then we thought, okay, we can do that with a stereotactic needle, which looks here for fluorescence. This is one point. But what about these vessels? And then we thought about the vessels, and we come up that white light remission to blood vessels would be or potentially helpful. So what we did finally, after a lot of kind of experiments, this is a sketch of this kind of biopsy needle. So it is a long, long needle here. Normally the tissue is sucked into this area here, and then by rotating, the tissue is cut out, and then it is removed from the brain for pathological evaluation. So we introduced 3 fibers into this needle. One which is looking forward. For this, there is an excitation at 635, and at the detection level here at the end, we can see light with a spectrometer, where we looked at the wavelengths of 650 and more to see the second band of this PP9 peak. So in the front-looking view, we can detect the tumor border. Then we have some side viewing fibers, 2 of them, and we send to through one fiber, we send white light, and due to the remission spectrum, we can discover whether here are some blood vessels inside. And if there are no blood vessels inside this tissue, then we can suck this tissue into this chamber, and then we can cut it out and make histology. So there is a potential benefit that we do not get some vessels in this area. Let's go further. What about the fluorescence or the selectivity of this 5-ALA? When you open a skull to remove a tumor here inside, due to this opening, sometimes this brain is moving a little bit, so it's called brain shifting a little bit. And what we see here is the leather skin around the brain. And normally now the medical doctors do not really know how to go further. This patient got some 5-ALA, and we came up and looked with blue light into this, shine blue light into this area. And what we found is that this is the fluorescence area here. And now the medical doctor can start to remove all the tissue. So this is for fluorescence assisted operations. This is how it looks like intraoperatively. So we are looking into this area right now. Here are the devices of the medical doctors. And when we start under white light, you can see that we cannot really distinguish between normal and cancerous tissue under white light. But if we switch to blue light, we have the blue light remission of the normal tissue and the red fluorescence. Here you can see it much more better. The red fluorescence here in this tumorous area, which cannot be seen normally in under white light. And here you can see the bluish remission of the tumors. And now we have a very nice and precise operation or removal. And based on that, we found that the solid tumor is marked with this 5-ALA-induced PP9 very, very nicely. But we have also some fluorescence in the infiltration zone. So there are a lot of tiny, tiny cells, and we can measure the fluorescence here. This is in the tumor, this is in the infiltration zone, this is outside in the normal tissue. So we are very, very low. So we have very, very high selectivity. We can calculate, and we can also we can measure the content of the PP9 by fluorescence here. And then we make a study about how much volume did we really receive from the patient. This black line here is standard procedure. So white light surgery with chemotherapy, with radiotherapy. If we just remove the solid tumor, then we got this area. I have to say that this patient received fluorescence guided resection plus chemotherapy plus radiotherapy. But if we remove also the infiltration zone, like here, then we can extend the lifetime for several months. So we are here roughly in the mean about 100 to 110 months. And this is the doubling time about. So the survival time depends on the residual tumor cells here. That is one point. And this procedure is approved in Europe since 2007. And since 2018, it's also FDA approved. So everybody can work here in the US in neurosurgery with this dye and with this concept. Nowadays also, there are a lot of operation microscope companies working in the field to make this blue light excitation and a very nice detection system to get this nice kind of pictures. So it is available, commercially available. So, but what can we do else? So there are still some tumor cells somewhere in this brain, and we cannot remove it because there are potentially eloquent areas. So then at this point, PDT, photodynamic action, comes on the stage. and we will have a look what happens there. So we have the possibility to shine light on the superficial one. So we make something like focal photodynamic therapy, or we make an integral photodynamic therapy, or we put some fibers into the tissue when the tumor is very, very deep in the brain. So it looks like this for the superficial application. This is a tumor. They do not want to touch this language area here. So this is the removal area. And in this area, they do not want to take too much tissue. Then we can shine light in this cavity because the skull is open. We can shine light in this cavity to make photodynamic processes here. Or we can use something like an integrating sphere effect when we take a diffuser in this cavity here. This is a cavity of the brain, a resected brain tumor. And we have something like a mirror here. And then we shine light in this cavity to get in every direction this light. This is how it looks like practically. And we can shine light and make photodynamic therapy on the surface. But what should we do with deep-seated tumors? So we need cylindrical diffusers, which can be put deep into the tumor. For this, we need to drill some holes into this, into the bone, into the skull, and then we can introduce fibers. So this is a stereotactic approach. But we need cylindrical diffusers, and we have to develop them, especially as class 3 products for these nervous system applications. So we make some calculations based on the optical properties of the tissues, which are somehow available. So we take the mean on several of these measurements. We calculate around the applicator what is the distance between 2 or more applicators or diffusers to reach 520 milliwatts per centimeter square on an artificial cylinder around the applicator. Because this is, from our experiments here, the value which is what is needed to get a proper photodynamic effect in this area. So when we put 2 applicators together in this brain, then we can go up to this value. This is roughly 4 to 5 millimeters apart from the applicator. And then we can reach, by overlaying this isodoses, we can reach this 520 here. We also need, especially for the brain, we also need to look what happened with potential thermal effects. So we calculated about the position of, in this case, 4 fibers, about the fluence rate and the induced temperature here. And when the distance is roughly 7 millimeters, then we have a temperature increase to about 42 degrees. And this is the absolute maximum which can be, or which should be applied to the brain because of edemas. So if we use 9 millimeters, a distance between the fibers, then we were a little bit below that temperature. And with this, also the medical doctors can live. So with this, we make, yes, with this, we are going into the clinic right now and do this kind of photodynamic therapy. So we did it first with 15 patients. They are de novo glioblastomas, small size. This was 3 to 4 centimeters in diameters, and we were allowed to do this. So normally, the mean progression-free survival after this STUP protocol is 7 months. STUP protocol, you remember, this is surgery, chemotherapy, and radiotherapy. Using fluorescence-guided resection plus chemo plus radiotherapy is 10 months. IPDT plus chemotherapy and radiotherapy, 16 months. This looks very promising. When we look into the 3-year survival, fluorescence-guided resection and the normal white light resection is very, very similar. IPDT is much, much longer, but for us as a scientist, it's just 50%. So, but we are looking more into detail in this 50% who live some longer. So this is a long-term progression-free survival, which are longer than 30 months. And that were 6 patients out of this 15 patients. And this ranged up to roughly 70 months. What happens there? Why are they so good? So we discovered that they have a very nice fluorescence in this brain. So a very high metabolic rate. And we need this high fluorescence at the very, very beginning. That is what we discovered from these patients. Therefore, we started to develop a device or a measurement technique to measure with these interstitial fibers the fluorescence in this tumor area. How can this be solved? So we have the fiber, it is introduced into this area, drill tiny holes just for introduction, and we put several fibers in this. When we shine light through the first fiber into this area, then we can detect with the second fiber attached to a spectrometer, we can detect the transmission, but we can detect also the potential fluorescence, which is in this area. And this is a spectrum what we get. Prior to operation, we have this transmission, a very high transmission. And we also have this fluorescence, so it's cut here a little bit. So we just look at the 700 nanometer fluorescence band. We have a high fluorescence here. And after operation or after illumination, also we do it not only between 2 fibers, we do it between all fibers that we inserted into this brain. What happened? At the very, very end, we measured again. We have a slightly decrease in the transmission, but we have an absolute decrease of photobleaching of this PP9 in this area. And we can see also some changes in the autofluorescence. So we have different changes, and now we are starting to look at what can we learn from this spectra that is right now under development. So how was a clinical approach? Normally, the medical doctors in the operation theater got the NMR pictures, and then we use the normal irradiation, so X-ray irradiation software, and we calculated a little bit that we need a certain area of interest around this kind of seeds, which is similar adapted to our effect range for the photodynamic therapy. And then we started after demarcation of the irradiated area or volume, we started to find nice ways to introduce several fibers from the several different directions in this tumor area. So they were placed there. Then these coordinates of the different fibers were transferred to a stereotactic frame. Regarding these coordinates, the holes were drilled into the brain. Here is the first fibers introduced into the brain of this patient. Then it is fixed somehow. Then a second fiber and the third fiber and the fourth fiber is placed in this brain, and we can shine light on it. But prior to this, we did our measurement with this spectral online monitoring. This looks like this. So we do the spectral online monitoring before. I have to say that it takes roughly 2 hours for this kind of treatment planning. Sure. And the patient got the 5-ALA 4 hours before this operation. And this is half an hour or roughly 1 hour before anesthesia. That is a very critical point. If you get it after anesthesia, then it doesn't work because the anesthesia reduced everything in the circulation of this patient, and then we do not get any fluorescence at the very end here in the brain. So we take some spectral online monitoring before. It takes roughly 3 minutes. Then we have a 1 hour tumor illumination by all fibers together. So we applied roughly 720 joules per centimeter fiber length or diffuser length. And then we make this spectral online monitor again at the very, very end. And we can see this bleaching. So yes, I can talk much, much more about newest developments in this case, but I think we should stop here. I would summarize that photodynamic diagnosis as well as photodynamic therapy are really dependent on the photosensitizer used. And using this specific one, this 5-ALA-induced PP9, we use the metabolic rate of the tumor, completely different to any other photosensitizers, where the photosensitizer is somewhere in the body. And okay, there is a transient accumulation potentially in some tumor cells. But the metabolic rate, once there is an uptake of this 5-ALA, then the metabolic rate of the tumor cells makes this PP9, and we just have to look by shining light in this area, and the tumor say, here am I. And this is a real advantage. So 5-ALA has a very, very high selectivity, not only in the brain, also in other organs. In the brain, especially in the brain, for chemotherapy, they have the problem to transfer the blood-brain barrier, because 5-ALA is such tiny, it can transfer through this blood-brain barrier. So it is also an advantage for this. We need also the optical properties to have a careful and good dosimetry concept. Every organ or every tumor needs a specific target approaches. So in this case, we use a stereotactic approach, which was really, really tough to develop together with companies and also with the clinicians, what they have and so on. This takes roughly 10 years. We need specific light application systems and a specific dosimetry concept. Regarding this light application systems, we need this class 3 products, especially for brain. These feedback systems are recommended, so the spectral online monitoring is really, really necessary, because we have seen that in one patient, he got the drug, this is an oral giving drug, he got it after anesthesia. And he was a failure in this PDT. And we do not know why. But when we checked it, that there was no fluorescence, and we did it with this measurement that there is no fluorescence at the very beginning, then, oh, what may happen in this patient? And then we go back to the protocol, what happened? And then we got the time when the 5-ALA was given. And okay, that was a wrong time. It was after anesthesia. And so on. So protocols are very nice to have. So in this case, also feedback systems are recommended to prove this. And yes. So, and since last year, finally last year, we are really allowed to make a feasibility study on patients with complete equipment. So we develop with a company together a laser on 635 nanometers, supporting eight channels for diffusers. We developed these diffusers with a company, made class 3 products with this. We developed a new stereotactic frame, and also this dosimetric planning is also developed new. And now it puts everything together, and we start with a real a clinical application. With this, I would like to thank all my co-workers and also the funding, and especially all the companies who are working also in this field. So thanks. Any questions? Sure.
I felt like the introduction was really interesting with the story of the student. I was just wondering, like, did you go on to keep studying on malaria, or like, did you just continue on what was found?
So the introduction, or?
That was like the background story.
So that was just the background. So now we are in the application phase. And originally, so my lab was established at the urology department. And we started in urology with photodynamic therapy and also with photodiagnosis. And we do this for photodiagnostic resection in the bladder. In the bladder, we can rinse it. So that was ongoing. And then we use the 5-ALA-induced protoporphyrin 9 in prostate glands when we have prostate tumors. And they are fluorescing pretty fine, and you can do it. And we did some experiments and clinical experiments, but in our department, they like it more to be surgeons, and they really cut it out. They think that is much more better. But another company, right now, it was approved, I think FDA, or even in Germany, is FDA approved to work like this procedure still for prostate cancer again. They're working with Palaporfin. This is a two-cut company. So, and yes, we are working on this all the time in dermatology and in gallbladder tumors also, and so on. And we need a lot of students to prepare all these tiny things together, especially for the fibers, this is technical parts. For the detection, we need IT to make all this evaluation process. And now we are thinking to correlate our spectral data with the clinical outcome, and whether we can something like do that, like a prognosis factor at the very end of the treatment, whether this is a good treatment or bad treatment. But we will see what happened. Yesterday, we also discussed a little bit about some different chromophores here. What we found during this reduction of the transmission, which I showed you, that these patients showed very early, so 24 hours, so 24 hours post-irradiation, the MRR showed T1 hyperintensity. Normally, this T1 hyperintensity is, from the surgeons, related to methemoglobin. And when we are looking at methemoglobin, this is a huge, broad absorption in 639 area. So this is a point that we do not get enough light at the very end. And maybe, we do not know at the moment, the photoimmunological effect of PDT, especially using this PP9, looks rather high. We do not know the combination, but the immunological effect is very big in this brain area. And maybe also this action at the very end gives this prolonged survival of the patients. Interestingly, the longest survival of one of our patients, so this was typically the first patient, she lives for 9 years after PDT. And she died by lung fibrosis, not by brain tumor.
What was the grade?
4.
That was asthma.
No, it was a glioblastoma. Yeah.
May I ask a provocative question?
Sure.
So how does this VDT outcomes compare with just interstitial thermotherapy? Because, like, I mean,
Yeah.
normal,
So,
you know,
so the normal, in normal neurosurgeons, there are some neurosurgeons who did thermal therapy, but it is not really established in the neurosurgeon department, and we also struggle with other therapeutic interventions here.
but is there
There could-
any comparison? Because they also
No,
have
there is
survival.
so far there is no real comparison. But from the physics point of view, I can give you an answer. We did it many years ago. This interstitial thermal therapy, but temperature is not selective. It is just temperature diffusion somewhere into this area. And when you stain the tissue with this proper photosensitizers, there is no overdose of this central part for this photodynamic reaction to induce singlet oxygen or something like that. So the normal cells outside this area are prevented. And this is cannot be done with thermal therapy.
Right, the issue is probably if you have comparatively big tumor, and you're right in the center, you have necrotic tissue, which probably will not.
Sure. So this is a problem. If we have this necrotic part in the center, we know there is really no answer. Right now, we started now with a real study. Everything what we learned from were more or less clinical experimental values. So there is no randomized study against something we do not know. We just see from this tiny group, and the group is right now, I think we have roughly 100 patients so far in these cases. And yes, they have a good overall survival and a longer overall survival together with a very high quality of life. When you make certain normal white light surgery, and you give this, this is a standard protocol, surgery plus chemo plus radiotherapy, then they have for their lifetime or lifespan, roughly in the mean 2 years, they have further chemotherapies in this. After this photodynamic therapy, they got once chemotherapy and this radiotherapy. And then so sure, we follow up with MRI, but we found that if we we have done a really good job on this patient, then they come back after 30 months, 30, 40 months, roughly, with a recurrent tumor somewhere, without any further intervention. So the quality of life in the meantime is very high.
Do you think that limitations of light penetration may be responsible for the cases because there will be
For sure.
and you have to
So there are a lot of possibilities. So we tried with the spectral online monitoring, we try to manage as best as we can. It can be. We know what we have done in, maybe I can go. We make some experiments prior to this. I already told with the prostate. First, we have to, and then I come back to your question. In the prostate, we have seen that endoscopically that yes, we have also this very nice fluorescence here, and we take some tissues from here, tissue samples, stained it like this. This is a tumor, and we can clearly correlate this with this PP9. And also spectroscopically, we can identify this. And then we were allowed on 10 patients to make photodynamic therapy in the prostate. And in the prostate, there are other possibilities. We have a transperineal approach, and we just stick, no, it's not shown here, we just stick several fibers into this prostate. And the only way we can control something, so we didn't control at that point, we have this PSA value. So pre-PDT, we have a high PSA value. After PDT, the PSA value was reduced. But we know in the follow-ups that after 12 months, the PSA increased. So we have no long-term effects. And at that time, we clearly know that we have a completely incomplete irradiation.
That's actually where I'm going. If it was possible to come up with some agent that would be more wavelengths, like around 1100,
would be great. Would be great. There are photosynthesizers which one can use in this field experimentally, but not in the clinics.
Right. I guess it's high toxicity.
It is toxic, and especially for the brain, it is. And you know that bringing pharmaceuticals into the hospitals or FDA approved is a real strange thing. And therefore, using this 5-ALA as an endogenous one, it was very easy. And now it is it is not modified. You can buy it at Sigma for your lab and so on. And the cells make this by themselves. And even you use some nicer molecules, photosynthesizers, you need the selectivity. That is a problem. PP9 itself, from the phototoxicity on cells, it is not the best one. Absolutely not. And it is, the quantum yield is low compared to other more toxic or phototoxic molecules. In this case, only the selectivity plays the role. And this is why I say PDT is not PDT. You have also always say, I use this dye or that dye and that dye. And most of the dyes are just somewhere in the body and a little bit more in the tumor somehow. But this is like chemotherapy. They are also not targeting really the tumor. They use these antibody things, and all this targeting helps. And with 5-ALA, the tumor himself say, oops, I'm here.
Two questions. One is
three.
technical. So did you show a nice simulation when you put the fibers and then you calculate the temperature and then you separate them and then it reduced? So what was the duration of the exposure?
At the very, very end, now we use 1 hour illumination in the brain, because we just illuminate with 200 milliwatts per centimeter diffuser length, not to overheat the tissue. If you use 300 milliwatts per centimeter diffuser length, then you have immediately around the fiber, you have a temperature increase up to 45, up to 50 degrees. That is, we don't want. And the placement of the fibers within the brain, we put it also nearby to the border of the calculated or visible tumor. And if we increase the temperature in this region too much, then we induce edema. And edema in a closed head is not that what a surgeon would like to have. And especially also in our cases, we know they got some edema. There are 2 days, sometimes 2 days of intensive care. And the surgeon sometimes, it's one night, he's a little bit sweating because of this edema, but he knows that the edema will be, is gone after 24 to 48 hours. But normally, every non-experienced surgeon in this field would open the skull.
And you mentioned the ALA is systemic. The way you administer 5-ALA is systemic, right?
In this case, for the brain, they can get it orally, so they drink it.
Right. Then, so the question is, is the optics, one is the dosimetry. How do you find out the dosimetry? And the second, like you may have variation in optic depending on the
Variation in optic, I don't.
like because different physiology, different patients, like and it's all over the body, so it may just be an optic.
So first, we have to say that 5-ALA, we make former times studies. This 5-ALA has in 5-ALA can be applied either by drinking orally. We can rinse it. So in the mouth, we wash the mouth somehow. So the ENT department make photodynamic also fluorescence detection in the mouth using this. And in the bladder, we instill for 2 hours the solution. And for lung cancer, in the bronchi, we can inhalate it. So there are different paths. Once it is in the, this 5-ALA is in the vessels, then it is also, and it finds some cells. Then, okay, in these mammalian cells, there is also this change in this metabolic rate, and they produce some PP9. And we have measured it on blood samples, and after 48 hours, there was no further PP9 in the blood. So it is very rapid. And the operations window for illumination for photodynamic therapy is in between 2 hours and 6 hours. There we have a maximum in this, and a maximum differentiation between tumor and neighbored tissue, because yes, it is just a transient accumulation and a transient selectivity. But it is very nice in this case. The transient selectivity of the photophrines, I think they have to apply it roughly 70 hours before operation, and then they have a factor of 2 between neighbor tissue and the tumor tissue. And here, especially in the brain, with a factor of 100. And it's a very fast kinetic in the, and we have no side effects because it is, in principle, first it is a non-toxic drug or a non-photosensitizer. In case of photophrene or something like that, you have it in the whole body, and you need to be protected from sunlight for 2 to 3 months because of skin photosensitivity. And this does not happen with 5-ALA porphyrins.
Do you need to do some treatment planning before you do this procedure?
Sure. Here. When we have a look at this side, so first, right now the treatment planning is like I would like to have is not established so far. So we have from the seed for radiotherapy in the brain, we have this treatment planning software from BrainLab. And we think that then we calculated our estimated photodynamic effect area to be about 4 millimeters in radius. Huh?
How do you calculate?
This is calculated by means of optical, so by measurements. So we measure the optical properties of tissue, we take literature of the optical properties of brain tissue, and we measure it by ourselves as well. And that so the whole branch for this specific wavelengths, and then we make the mean.
Okay.
And with this, we calculate the.
So it's empirical, based on empirical correlations.
Sure.
You're calculating.
Yeah, but. And with this, so we make an assumption that this reach of these seeds of a specific gray is similar to the reach of our PDT action. And with this, we make on this kind of pictures, we implant virtually the seeds into this brain, into this area. And with respect to the seeds, we take the fibers.
But the seeds were different frequency radius.
Sure, but we can, they also have an assumption that they have a reach of, so we can use seeds for 3 or 4 millimeters distance. And so we make this assumption correlation.
I see.
It is not finished so far. So, but we are working on a real optical way. And working on a real optical way is also when we look, where is it? This way. So we have this, in this example, we have 5 fibers. And we measure in between the fibers the spectrum. This is a spectral online monitoring. And we can derive from these calculations by diffusion theory and also by Monte Carlo simulations about the mean optical properties in between these 2 fibers based on this spectrum.
Yeah, but you know, in Monte Carlo, how do you base it on? What are your cross sections? What are your probably densities? So you need to know the angular distribution of.
Absolutely right. We don't know about that, but we have values from non-patients. So we have from samples, patient samples. We have some, but they are also not true. But you cannot use this one because this is we measured it in living patients, and we cannot measure it in a living patient. That is a problem.
I think there is also publication on brain optical properties for in vivo. One from Lausanne.
No,
No.
unfortunately not. We are close together with Lausanne, so really optical properties. So we take all the literature together, yes, and we search for this and we try to put them together. So we take the mean of all this in the, what we can get, and we improve it.
So what you're
every
saying
time.
is basically everything that has been measured is incorrect because you cannot use it. It doesn't work.
It works in certain amount, but it depends on what you want, what you mean, what is working. So you can make calculations, Monte Carlo calculations with every amount of factors and optical parameters.
Yeah, if you could use
But
published optical properties, it would have been much quicker, right? Than if you have to personally measure each patient.
But your brain is different to mine, and therefore the optical properties of your brain is different to mine, and especially your tumor, or I hope you don't have, but this individualized tumor have specific optical properties, especially as you mentioned, we have a living area and we have a necrotic area, and we have also during this illumination, we have changes in the blood, methemoglobin. So what we are doing right now, we recalculate from this kind of spectra, we recalculate in an inverse model a possibility of mu-A or of mu-A, a possibility of mu-A. We do not really get the real answer. We do not know.
So you need absorption because basically the penetration probably is defined by scattering.
Both. There is absorption and
You're talking to the wrong person. You will never convince me because I've been in optical properties for so long. Optical range is like 1 or 2 orders of magnitude higher scattering. So you can forget about absorption altogether if you're talking about penetration. If you want to figure out absorption of the
Because there's some people say water is high absorbent.
that will be in the infrared. That will be starting 925 and even probably 1200. Also, if you are exciting in the blue, then the red band definitely can compete with scattering. But anywhere
for sure, but you are right. I do not want to discuss right now optical properties. I just want to tell you what we are doing and what we can do within this patient. We can measure in between 2 fibers what happened or what is a diffusion or the mu effective something in this range. Yes, that we can calculate somehow, and then we can hopefully in the future. So we have a different mu s prime in this, between these two fibers and between this fiber and that fiber and that fiber and that fiber. So we got a bunch of mu s primes. So we have something like, but this is, we can calculate afterwards so far.
No, but how much different are those? I'm just curious.
They are different. Up to 100%. So there are,
Sounds very challenging.
it is challenging. So we are working on this field and also in this development right now for more than 10 years. So, and therefore we need a lot of students, make calculations and experiments and all these things. Further questions?
Well, there's two messages in the
Ah,
chat.
sure. Let's have a look. Chat. I have to go. Bye-bye.
Oh, okay.
And another meeting? Okay, bye-bye.
Easy questions.
Easy questions.
Yeah, what's?
But we can discuss further.
I just have a quick question. So you mentioned the need for like target-specific approaches. So for the fluorescence-guided neurosurgery, I was kind of just wondering, is there any effect on the the site of the tumor in relation to its efficacy for, the ultimate outcome, which is prolonged survival? So is there any need to adjust the protocol, whether this is a glioblastoma that's near the surface of, say, the parietal lobe versus
About the location, there is so far there is no real evaluation on that. So about locations, but what we found is that the medical doctors are more or less like to use this because they have the problem to differentiate between, as I showed here, between normal and tumorous tissue in this case.
Yeah, I just wasn't sure if the location in the brain could somehow impact the concentration or distribution of the fluorescence agent or surrounding tissue.
Maybe so far we did not measure.
And are they using fluorescence guided surgery? Is there any other organ type or malignancy besides brain cancer that
For sure, you can do it in, so I know a lot of dermatologists who make Mohs surgery based on fluorescence. I also know a lot of urologists who make fluorescence guided surgery in the bladder, in the urinary bladder for the small and tiny tumors clinically. And it is approved and it is, for me, it is established. So in Germany, you can get it if you're going to urologist and there is some hint that you may have some tumors in the bladder, then they rinse your bladder with 5-ALA, and then after I think 2 hours or 3 hours, then you come for cystoscopy, and this cystoscopy is then with this kind of light, with blue light excitation, you can clearly see from far away, oh, there is a tumor, there is a tumor, there is a tumor. Especially the big ones, the papillary tumors, are not of interest because I can see it. Of interest is our tiny satellites, and they can diagnose these tiny satellites in the bladder. This is a size of smaller than a millimeter. And this is just by resection loops. Remove it by resection loop.
I believe here it's just brain surgery is guided by fluorescence.
No.
In terms of FDA approval.
Here in US,
Yeah.
yeah, possibly. I do not know.
I thought they were looking at thyroid.
But once it's approved by the FDA, clinicians can use it off-label. So even if it's approved for glioblastoma, so you can use it off-label if you are a neurologist because it's already deemed safe for the brain.
So the devices are medical approved. So the devices are available. You can just go to Storz and say, please send me the light source.
For think
Was device.
device. Because you need to guide surgery, you need to see the brain.
So in urology, Storz company as well as Olympus, they built up lamp source, normal lamp source, and they filtered it a little bit. Then they got this blue excitation light. And on the cystoscope, we put a filter on it just to have a little bit blue light, just for orientation, but most of the red light transmission. So we protect a little bit the blue light because it is very bright. And then we have pictures like this.
I was just wondering if places where it's like approved, like the urologic surgery, like what percentage of the urologic surgeons are using this technology? Is it like 100% of them use it? Only 50%?
So in Germany, so that was done in the 90s in Germany. I don't know how many urologists are there doing, but if you're talking to urologists, it's normal in Germany.
So it's almost like
I do not know whether how it looks like here in the US. So we should make maybe a search on it. And regarding the steroid application you are working on, we have done also some steroids with 5-ALA fluorescence, and they steroids. Tumors fluoresce very, very well. Unfortunately, I don't have right now in my brain, the knowledge whether they just differentiate between benign and tumor, or potentially they can also see different tumor stages. And I personally, because I'm right now here, I would be happy if you can do some experiments somehow, similar like with methylene blue, with this 5-ALA induced protoporphyrins, to look whether further differentiation in your evaluation would be possible on one hand side, and potentially if fluorescence polarization technique may also have an improvement in this, because we do not do fluorescence polarization. This is just fluorescence.
And do you have data on fluorescence lifetime?
It is very hard to get fluorescence lifetime. We did some measurements, fluorescence lifetime measurements on time correlated single photon counting, but it's really hard on cells.
Because it's just, if it's we are in the hundreds of picoseconds, short. We saw the same effect with tetracyclines, and it's even shorter fluorescence lifetime. If it's a long fluorescence lifetime, which it would be if it's triplet.
I do not know exactly. So
the state will live longer than polarization fluorescence will be depolarized.
I do not know. So with this, you have to look for the publication of Angelika Rück. So this we did together with Angelika.
She works with Koenig, right?
That was 100 years ago.
That is probably not her.
Huh?
It was 100 years ago. That's probably not her.
Yes, so no, they started together, but they are, so from the academic point of view, both are retired, and Angelika is still a little bit working, so 20% somehow, and she is still in Ulm, and she leads for this 20% her microscopy lab.
So very interesting. Amazing talk.